my second charge was to give you some information about donation for those of you who might be thinking about it. And the title I was given was, Have You Asked Someone to Be a Donor? But I'm going to be talking about deceased and living donation, so you have an idea about how organ transplants happen. I got it. Okay. So my objectives here are more limited. There have been some changes that have come to UNOS. UNOS is the acronym for the federal contractor that operates the national contract that oversees the organ transplant process for every organ, that comes up with rules about how we allocate organs, that comes up with things that we must do to make sure both the transplant recipient and the potential candidate are being evaluated appropriately, have the expected outcomes, and so on. And they've created some new rules, which are constantly fine-tuning how we allocate organs, because there are disparities in access to organs that can sometimes be changed by changing the rule book. Unfortunately, what that does is just, just rearranging the deck chairs, if you will. You're just changing who gets an organ. You don't really necessarily have an impact on the total number of people waiting. I'm going to talk to you again briefly about the types of living donation that are possible. That's daisy chain, LRD is living related donation, and DD is deceased donation. I'm going to give you some resources so you know how you make that ask, because when you're on the transplant waiting list and you know a living donor is best, how do you actually approach someone to ask them to be a living donor? You don't actually do that. You don't ask them, but you find creative ways to bring up the topic of the fact that you have kidney failure, that you're on the transplant list, and invite a conversation and hope that it happens. And I'm going to give you a resource to go to this website from the National Kidney Foundation. National Kidney Foundation, you probably already know, is a private patient advocacy organization that's by patients for patients, that has a number of resources, and it has a number of physicians and other professionals on its advisory board and on its board of directors. So the information they provide tends to be very accurate. So where do organs come from? Very simple question. Most are coming from deceased donors. These are donors who are diagnosed as having died, either brain dead, that's when their hearts are beating, but many organs are still functioning. Basically, they're on life support. The kidneys are working, their liver is working, their heart is working, but their brain has stopped functioning. And then kidneys come from the traditional donors, the donors that existed before we had life support systems providing brain dead organs. And those are people that die because their heart stops beating. We call them the circulatory death or cardiac death donors versus brain death donors. And then we have living donor organs that come from healthy people who meet certain criteria for donation, who are able to understand the risks, because living donation is a major operation. It does come with all of the standard risks of any major surgery. And it's being done to an individual who doesn't necessarily benefit from that surgery. So it's an area of medicine where we breach the principle of first do no harm, because here we're doing harm or potential harm for the sake of another. And they need to be able to consent. So they have to be above the age of 18 and be competent to give consent. This is just to tell you that the number of transplants over the years have slowly gone up. That's from 2010, and that's 2020. So that's a 10-year horizon. That's a total number of transplants. Back then, it's now up to 28,000 in 2023. That's the number of deceased donor organs. That's the number of living donor organs. So it tells you that although deceased donor organs have increased over the years, and that's related to increased recovery of donor organs and the increased utilization of those donor organs, living donor transplant rates have not changed appreciably in a long time. I told you briefly about UNOS, the contract they have or the network they operate has a name given by the federal government called the Organ Procurement and Transplantation Network, or OPTN. So UNOS and OPTN for now are interchangeable. UNOS operates OPTN, but if UNOS loses the contract, some other entity may operate the OPTN. And the OPTN has no other function other than to regulate organ procurement and organ utilization. Organs are also procured by federal contract organizations called organ procurement organizations, and they're charged by the federal government of procuring the deceased donor organs, and UNOS makes the rules of where it goes. In the past, that's the rule that has changed. Donor organs preferentially stayed in the locality that they were recovered from. Now they travel further. So this is not a map of the states of the United States. This is a map of each of the 52 organ procurement organizations that exist. Some of them cover an entire state and no more, like Nebraska. The Iowa organization covers 99 of the 100 counties. Some OPOs cross many states, and some states have multiple OPOs. So it varies. It's all dependent on organizations that bid for a federal contract. And in the past, organs in those regions stayed within those regions. And that has led to, that's among the many reasons why there are disparities in access to transplantation. So this is a statewide map of the US. And the more transplants you have, the darker the state, the fewest transplants you have by unit population, the lighter the greenness. So Hawaii has the fewest transplant rates, while Iowa and Utah in this map, as of 2020, have the highest transplant rate. This is in part because of the organ allocation rules, and in part a matter of the number of deceased donor organs compared to the number of patients who have kidney failure. And I've just told you that. So what are the changes that have come? This has now been in existence, I want to say 2 or 3 years. They're now going to be preferentially allocated not by that region, that local organizational jurisdictional area, which is very loose and arbitrary and varying sizes, but they're going to be allocated within a 250-mile circle from the donor hospital. And eventually we'll get to a point where there'll be a continuous distribution model. Now we're limited by transportation times and so on. So we're keeping it within a 250-mile circle. And the intent here is to level the playing field. So places like Hawaii or San Francisco or New York City, which have waiting times of 10 to 15 years for a deceased donor organ, start to see their waiting times come down. And consequently, our waiting times will go up. That's by design. So there again is the map of the OPO. So now, for example, if you will recover a kidney in Iowa City, that's the donor hospital, there will be preferential access to patients in Iowa City, not patients who live in Iowa City, patients who are on the wait list for a transplant in Iowa City. So you could be in Vermont and on the Iowa City wait list. If a donor organ comes up in Iowa City, preferentially you'll be allocated that organ. Now, that's not the only criteria that is used, but proximity to the donor hospital gives you significant advantage. When you're choosing a hospital program, you'd want to be thinking about proximity to home because you may have to travel frequently to your transplant center, and at times that may not be opportune for you because the kidney must be evaluated and maintained. You'd want a program with an active living donor program, including paired exchange, and we'll tell you a little bit about paired exchange. It allows us to expand the options for potentially incompatible living donors. You want a center that has high transplant rates and good outcomes, and these are, by the way, all in the public domain. And you'd want to, if you have the resources, consider listing at more than one transplant center. You're basically increasing your probabilities of being listed at a transplant center where an organ will become available. And that second transplant center ideally should be 100 to 250 miles away, so you're not getting the same organs from 2 different centers. And obviously, a living donor is best. And I've just told you this, areas with shorter wait times will lengthen, areas with longer wait times will shorten. It'll take a while, but it's already happening. All right, living donation. So deceased donors are listed with UNOS, and they have to wait their turn. And among the many things that go into this allocation model is the likelihood of benefit for the recipient, for that particular donor organ quality, for the time on the wait list. It's a very important parameter that determines how long you'll wait before you get your transplant. Your blood group, whether you have an HLA match. HLA are those antigens that are different between you and me, that happen to be recognized by the immune system, that tells the immune system that you are different, that kidney that I have in me is different, and I must attack it. So the better the HLA match, the more points you get in this allocation model. So if you have a perfect match, you tend to get preferential access to kidneys that come from much further away than the 250-mile circle. And then I told you about the proximity to the donor organ. And for living donors, it can be pretty much anybody in terms of relationship to you. They have to be healthy. All those parameters I gave you in the beginning, they typically, and to start with, were always related: parent, child, sibling, now uncles, nieces, grandnieces, can all be donors, and they can be unrelated. Those that have strong emotional connections, like a spouse or a best friend, but it could also be an acquaintance, a church member, somebody who is in your organization that you are a member of. It could be a complete stranger. We have all over the country, we have people who volunteer to offer a kidney to someone. They don't know anybody who needs a kidney transplant, but they feel they have two perfectly good organs, and they think they should be donating when they're in the prime of health. So we have those non-directed donors. And then we have this kidney exchange to help us provide the best match for recipient donor pairs where they are incompatible. So the benefits from a kidney transplant, typically it works immediately, it works longer than a deceased donor kidney, and it can be electively scheduled. It's not at 2 o'clock in the morning when you were just planning your vacation to South America, but at a time that is convenient. If you're a teacher, it could be in the summer when you're off from school, so you can recover fully from your surgery. And if it's a donor, likewise, recover fully from surgery and get back to work without interruption. And most living donors are done with incompatible transplants. That means they're either blood group compatible, and certain blood groups go to certain blood groups. So AB, the recipient AB, is called a universal acceptor. They can take blood group A, B, O, or AB. So there are 4 blood groups: A, B, O, and AB. AB blood group people can receive kidneys from them all. They're all compatible. A can only take from O or A, and B can only take from O or B, and O can only take from O. So O is a universal donor, AB is a universal acceptor, and everybody else has some restrictions. So that's one type of incompatibility. The blood groups just don't match. The second type is where you have already created antibodies against someone's HLA system, and that donor of yours may not be someone that you can easily take because you've got antibodies against that person. And that sometimes happens because of a prior pregnancy, prior transfusion, or a prior transplant. And then we can also use paired exchange not only for people that are incompatible, we could use it to better match a person. So we're taking a well-matched donor-recipient pair by HLA and by blood group, but we might, for example, say this is a 20-year-old child and the 80-year-old grandfather wants to be the donor. That's a substantial age difference, and we all lose kidney function as we age. If we can put that pair into the exchange system, there may be a 70-year-old recipient candidate who's got a lot of antibodies, who's just not getting any match. That 80-year-old kidney would be a perfect match for him or her, and their own 20-year-old niece can't donate to grandpa or granduncle because they have these antibodies, but it may be a perfect match for this young recipient of yours. So we find ways to create more compatible donors even within the compatible donor system. We have 6,000 patients who have a willing but incompatible living donor in the US on average every year. And that comes from those incompatibility from HLA or blood type. So our options are to try and get rid of those antibodies by a process we call desensitization. It's a pretty aggressive treatment where we do plasma exchange, rituximab, and sometimes afterwards we may need to do splenectomy. So it's a very aggressive form of therapy, but in countries where pair exchange isn't well established, where deceased donation is not a common thing, like in Japan, a lot of ABO incompatible transplants happen. The preferred way to deal with incompatible donor-recipient pairs is really the pair exchange, which has gotten to a great place in the US. So it's very well worked out. We have the ability to transplant people across many hundreds of miles, and it has results that are just as good as direct donation. So that's the preferred approach. Doesn't require the recipient to get those additional powerful medications, and it allows the transplant and the donation to safely occur. So based on blood group frequencies, there's a 35% chance that any two of us in this room are ABO incompatible. And I gave you some examples of this ABO incompatibility earlier. And that's because when we are born, before we're exposed to that other blood group, we have naturally occurring antibodies. So blood group antibodies are naturally occurring, does not require prior exposure to that protein or antigen, while HLA antibodies come from exposure to HLA antigens. And that comes, as I said, from transplants, pregnancies, blood transfusions. And when you're on the waiting list, we're frequently checking you to see whether your antibody profile is changing. And if they are, then we have to inform the allocation agency, UNOS, that you now have antibodies against HLA-A2. So no A2 organ should be allocated to that individual. It helps to make the process of allocation and acceptance of organs much more efficient. And we determine where you are on the wait list by calculating the fraction of antibodies you have against the US population. So if you have a CPRA of 100, it means you have antibodies against 100% of the US population. It's not truly 100%. Anything above 99.5 is rounded up to 100. And if you have a CPRA of 10%, that means you react against, on average, 10% of the population. And we don't typically cross that barrier, because if you transplant an organ to a recipient that already has those preformed antibodies, you can get a fairly vigorous rejection response, sometimes that may not be reversible. So that's where kidney pair donation comes in. So the concept here is, if you had two couples or two pairs, I guess you may not be able to see this very clearly. That's a B recipient and a B blood group recipient and A blood group donor, incompatible with each other. And then there's this other pair where the recipient's A and the donor is B. And conceptually, it's very simple. This donor donates to this recipient, this donor donates to this recipient, and it's all well and good. We also have variations on that where you can do a three-way exchange. So now there are three pairs. Or you can do these never-ending chains. You can start with a non-directed donor, someone who has nobody to donate to, and you find the first of the two pairs that are incompatible. The recipient receives this kidney, his donor gives to this woman, her donor gives to this person, and then at the end of that, there is a donor who hasn't yet donated, but that donor can now start another chain. And we have fancy names for this. This is the daisy chain for this non-simultaneous extended altruistic donor chain. And that's apparently what a daisy chain looks like. I had to Google it. I have not seen that thing named that way. All right. So how does the donor kidney get to the recipient in kidney pair exchange? In the past, recipient either traveled to the donor center, which was taxing for the recipient, or the donor traveled to the recipient center, which was inconvenient for the donor because he or she wants to be with their loved one who is going to get the organ in exchange for his or her donation. And they don't want to be away from their intended recipient. So these days, donor kidney is removed and travels to the transplant center by plane or by courier or by land. And it requires coordination of transportation and OR times, sometimes between the East Coast and the West Coast. And as I said, you can travel the entire length of the United States or the entire breadth of the United States and still do just fine. So I've got 30 seconds left. Here's my last slide. Learn about living donation, talk to living donor recipients and to former living donors if you're interested in being a donor. Share your story if you've either been a recipient or a donor, so you help motivate others in the community to step forward. And then there are these resources that I've named, and I think it should be in your handout, including the Big Ask, Big Give from the National Kidney Foundation. So I think I got my 30 seconds in. Thank you very much.